You're welcome back to the Arise interview. We're live in Nigeria's capital, Abuja. I am Christian Ogodo. Thanks for staying with us. A World Health Organization modeling study says the coronavirus could kill 150,000 to 300,000 people in Africa in a year unless urgent action is taken. The study also estimates that nearly 250 million people will be infected. Authors of the research, published in the journal BMJ Global Health, predicted a lower infection rate than in other parts of the world like Europe and the US, with fewer severe cases and deaths. But while they said many African nations had been swift to adopt containment measures, they warned that health systems could still quickly become overwhelmed. The study comes amid stark warnings that COVID-19 threatens a health emergency in developing nations where fragile health systems are already struggling with an array of other chronic diseases. And for more on this, let's turn via WebEx to Professor Adebola Olayinka, who is an infection prevention and control expert and research officer for the World Health Organization here in Nigeria. She joins me, like I said, via WebEx from Kano. Hello, Prof. Nice having you on the program.
Yeah, thank you. Good evening.
It may not be such an auspicious time. You're far away in Kano, where the pandemic, COVID-19, is ravaging that city. What are your findings so far with the earlier deaths there? Is the WHO investigating the cause of deaths too?
Oh, well, the Federal Ministry of Health had sent a team there for investigation, and the Presidential Task Force is investigating. What we are doing is supporting the training of healthcare workers on infection prevention and control, because a significant number of healthcare workers also died from the infection. So we are building capacity in such a way that healthcare workers can provide care without getting infected.
And I'm sure it's because of this that the World Health Organization based its warning that between 150 to 300,000 Africans will likely die from the disease, the coronavirus disease, and saying that another 30 million Africans are in danger of falling into the poverty line. So why? But one would ask, Africa still has a lower rate of infection and even death compared to Europe and America, the US. So where is this analysis and data coming from? What is it based on?
Thank you. Such analysis is usually based on what we call modeling in epidemiology. And modeling is based on looking at what current data you have and making some projections as to what could happen in future. But one of the things that that article talks about is about the fragility of our healthcare system. And that we really need to have a look at. We have healthcare facilities sometimes without adequate infrastructure, adequate supplies, and our insurance system is not really working at the community level. Now, when you're talking about a healthcare system that is strong, you look at a number of things. Some of these I've mentioned. Number one, are patients able to access care? Access now in terms of distance, access in terms of expertise, access in terms of the facilities they need, access in terms of having even whether you have a financial access or not, or insurance covers you to be able to have the care you need. And so this is the fragility of our healthcare systems. We still have a lot of gaps and challenges in these areas in Africa. So talking about the fragility of the healthcare systems and the prediction of maybe a significant number of deaths, it's because our healthcare system may not be able to provide the supportive care that is needed. with COVID and other comorbidities. It's important for us also to understand that Africa already has a host of some endemic diseases, which by themselves lead to significant mortality and morbidity among the populace. We have HIV, we have malaria, we have tuberculosis, we have parasitic infections, we have bacteria infections and other viral infections. We've got Lassa fever. We still have Ebola in some parts of Africa. Now having COVID-19 on top of this tells us that the prognosis might not be very good for the African nations. And I guess that's why that prediction was made. I also think the prediction was made to ask African nations to begin to prepare and not just assume, oh, we have low numbers. If you remember when COVID started in January, the Director General of WHO, as far back as January, he declared the COVID outbreak a public health emergency of international concern. But then many nations still felt, oh, it was far away in China. And then he had to come back in March and say, look, this is a pandemic, but he had declared it a public health emergency of international concern about 2 months earlier. So I think the essence of this is to tell African countries that, look, we need to begin to build up our healthcare systems to be able to cope with what may come forth in future.
Good submission there. The prognosis, you say, might not be good for Africa because of its health care fragility. And we've seen an African country that has come up with what it says is a solution for the COVID-19, the COVID organics by Madagascar. Why is the WHO so quick to condemn the efficacy of that herbal mixture?
Oh, well, I don't think WHO condemned the efficacy. WHO warned that the efficacy needed to be proven. So those are two separate statements. So it wasn't a condemnation. It was more like we need to provide the evidence that it really does what it's said to do. And that is normal in science. We are always looking for that evidence. We look at things like the risk and the benefit ratio, because even the modern drugs we use, they all have adverse effects. So a nation has said this is effective. Okay, we are not disputing it, but we are asking, where is the evidence of its effectiveness? And not just its effectiveness, it's also important to have the evidence of its safety. And I think that was WHO's position, not necessarily a condemnation, but a request for the evidence.
If you say so, you want to kind of update us on what's been done so far, the progress being made on getting a vaccine, not necessarily curative, but managing this virus. What's the latest from the WHO about the thousands of scientists all over the world in a race to get a vaccine out?
Well, WHO is not the one developing the vaccine. WHO, as the UN agency in charge of health, is just ensuring that the development is being done in a scientifically safe way, such that when we have a vaccine candidate, it will be safe in administration to people. It will pass through all the phases of clinical trials that needs to be done. And so the various vaccine developers are still working on it, and we're all still waiting. A few have started what we call the first in human trials. Some are still at the animal study phase, and there are different phases, but it's still a waiting time and a waiting period in terms of the vaccine.
A waiting period indeed, but what hope does animal trials offer for a vaccine right now? Because you said that there are trials ongoing. Are there hopes? Are there signs that, you know, something is going to come out?
Vaccines go through animal trials first before they are tested in humans. And that I do not have I don't have the figures on them. I know that a few have started what we call the first in human trials, like the one that was made known on the internet by the University of Oxford. So which means it must probably have passed through the animal trial phase and showed some promise, and then they've started the first in human trials. But even then, it's still too early to talk about its success. So a success in animal trial does not automatically translate to being successful in humans, but it's a necessary phase that vaccine developers go through in evaluating the potential usefulness of any vaccine.
Okay, let me take you back to Madagascar because of the political. I know you're not a politician, yes, you're a scientist, but I'll take you back to Madagascar. The president there said it is the herb mixture, which is COVID organics, is very good. It has cured some people. Some African countries are taking delivery and the rest. Has the WHO itself taken samples, delivery of this and put it and subject it to scientific tests to see if it's really efficacious?
There's a way that scientific experiments are conducted. You're going to need somebody like now. What would be expected is that the Madagascan scientists should develop a protocol, should do the science in a way that is acceptable to the scientific world to prove the safety and efficacy of the vaccine. And there are standard ways and standard protocols to do this. So it's not WHO doing it, it's the International Scientific Committee who is interested in this, doing that, and then WHO evaluates the evidence that is provided.
Professor Adebola Olayinka, we'll be back. We just want to take some messages. You're still watching the Arise interview. We've got plenty more still ahead. Stay with us. You're welcome back to the Arise interview. We're live in Nigeria's capital, Abuja, and I still have with me Professor Adebola Olayinka, who is an infection prevention control expert and researcher with the World Health Organization, WHO. She's in the Nigerian office here, and we are live to her in Kano via WebEx. So, is not yet hope arise, so to say, because of the race by scientists to really get a cure. But already the WHO seems to have approved a drug that was used for Ebola a few years ago. I'm talking about the remdesivir. How has science come to say, well, they've said that about 50% curative protocols, you know, after testing on humans or treating some human beings in America has been effective. Has the WHO bought into this, Prof?
Let me lay some background. WHO does not approve medicines. You have regulatory bodies within countries that approve medicines. For example, in the US, you have the FDA. The equivalent in Nigeria is NAFDA. The second background I would like to make clear is that developers of drugs are the ones who do the initial studies and provide the evidence of those studies. For example, they provide toxicity studies, and they provide the results. They talk about the dosing, they talk about the route of administration. That is the work of the developer. Now, regarding remdesivir, WHO is not the one to approve it. And so I won't say WHO has come out to approve any drug. WHO has not approved any drug. What WHO has tried to do is what we call a solidarity trial. And contrary to what has been on the internet, it's not a vaccine trial. It's actually a drug trial. And it's a drug trial using drugs that countries are already using to treat COVID. If you take an example, even in Nigeria, you will find out that across different states of Nigeria, we have different treatment centers using different drug regimens. Now, the way we are using these drugs, at the end of the day, we may not really be able to prove how effective these drugs are. And so the Solidarity Trial is actually to get a number of countries on board, having looked around the world and seen what drugs are being used globally in a lot of the treatment centers, and then putting this in a scientifically controlled manner so that at the end of the day, we would have the evidence of which one of them works best, what are the adverse effects associated with most of them, and being able to chart a way forward in terms of appropriate treatment of COVID-19.
So quite a number of discharged patients here in Nigeria have complaints to say that, look, they only had malaria and the rest, and all the period of isolation and treatment, it was malaria medications they gave them and the rest, that this COVID virus, sounds very alien to them. I don't know how you're going to respond to that, if the people are ignorant or not,
Yeah, I think somehow we have not effectively passed the message down to Nigerians. The first thing Nigerians need to understand is that over 80% of people would have very mild symptoms. The symptoms are so mild and sometimes so fleeting. They don't last more than 1 or 2 days in some people. And so they feel, okay, I'm okay. Now, the reason why we ask people who test positive to be isolated, it's not really necessarily because they need treatment in terms of drugs, but we are isolating them to prevent transmission. So I think somehow people feel isolation, the need for isolation is equivalent to the need for some kind of medications. For people who are asymptomatic or mildly symptomatic, they really may not need to have any antivirals or whatever, but we isolate them to protect the people around them. Because even though they do not have symptoms, even though they do not feel sick, they are shedding the virus, and as they're shedding the virus, they're transmitting it to all who have contact with them. And that's why when people are kept in isolation, they keep getting tested until they test negative. And so when they test negative, that is an indication that, okay, now you are no longer shedding the virus into the environment, and you can go back into the community because you will not be transmitting it. So the reason for isolation is not primarily to administer drugs. The reason for isolation is to break transmission and prevent transmission to others. So that message, we actually need to get it out to people. So even if someone is in an isolation center and all the person is getting is vitamin C to boost the immunity or zinc, it's okay, because it means that person's immunity would eventually overcome the COVID-19, but we need to isolate that person to prevent transmission.
Those who complain, those who had gone in and out, who complained that they were only treated for malaria, at least one prominent Nigerian who is a medical doctor but more of a politician said so much about that. And another who who is one of the doyens of broadcasting in Nigeria said as much. So how do we isolate people with just malaria that is common everywhere, and with the normal dongoyaro, those in the rural communities would treat themselves and get well?
I don't think they were isolated because they had malaria. They must have tested positive for COVID to be isolated. But just like I said, they may have had very mild symptoms. Maybe they just had headache, things that feel like malaria. Yes, they were treated for malaria, but we don't isolate people who do not test positive. You test positive, you get isolated. You test negative, you get discharged. That's the simple protocol.
And that simple protocol is that it develops from fever, feverish condition, coughing, sneezing or having catarrh, it's still seen as common colds in this part of the world.
It could mimic malaria, and that's why really until you test, it might be difficult to know who has it or not.
I've argued against using the word isolation center. That somehow it has a kind of psychological effect. You know, it's like a form of detention. I mean, particularly the National Human Rights Commission said so much that it rather should be described as a treatment center. Don't you think so?
You know, it's a matter of words, because if you look at the concept of a treatment center, and then somebody says, okay, I was put in a treatment center and I wasn't given treatment. And people are already talking about that, feeling that all they had was malaria and they were kept in a treatment center. So yeah, I think you understand how it is between the devil and the deep blue sea in terms of the nomenclature. But maybe we could start thinking of a more appealing word. I wouldn't know what the synonyms are for isolation, but we can begin to start thinking about that. Because the truth is, the concept is actually to like isolate the person from others so that you break transmission. And then the isolation is only for a period of time. It's not a permanent isolation, but it might be good to think about a change in those words.
In another 1 minute, can you attempt to tell us, the world has focused so much on this coronavirus. We still have Lassa fever, you know, still ravaging our people. It's going down now because the weather is changing. We still have Ebola in some parts of Africa, in DRC. It's still very prominent. The World Health Organization seems to have shifted complete focus to these coronavirus. Prof?
No, I won't say we've completely shifted focus. Yes, there's a lot of focus on coronavirus now because it's a pandemic, but the focus hasn't shifted. Recently, we talked about immunization of children because that is still something on our focus. The eradication of polio is still there. The attention to all these other epidemic diseases, there's still a focus on Lassa, even in Nigeria, as we talk. And then as we move to the seasons, we would be expecting
all right,
to come.
Professor, I must thank you so very much for the enlightenment of what WHO is doing and what WHO is doing, and your team in Kano too, giving support to the federal government. I've been speaking with Professor Adebola Olayinka. She is an infection prevention control expert as well as a researcher with the World Health Organization in Nigeria here. Well, that's it for this edition of the Arise interview. Do join us again for another edition, and from me and the entire team here in Abuja, goodbye and thanks for watching.